Now moving on to our next section, that is the undisplaced and displaced fracture of the distal radius. In this section, we will be first going through the undisplaced fracture, in which there is a fracture but the parts have not displaced out. Then we will be discussing the displaced fracture, which may have intra-articular extension, and how the impacted low energy distal radius fracture have different complications, how they can be dealt in, and what are the associated complications with them. Coming to the undisplaced fracture, usually the dorsal splint for a day or two until the swelling resolves. If they are undisplaced, if you see there is a fracture, but this seems to be undisplaced. In this case, you don't need to even give a POP. You can simply give it a splint so that swelling resolves. Once swelling resolves, patient can restart movement within a week or two. The cast is usually completed and X-ray is taken at 10 to 14 days. You give minimum 2 weeks so that a soft callus starts to form, and then it can gradually turn into a hard callus. And usually by 5 weeks, we can remove this cast to allow complete mobilization of the wrist joint so that a maximum range of motion can be done. But that is only if it is undisplaced fracture in both the medial and in AP and lateral views. That is important. On both views, provided there is no associated radius ulnar fracture, the elbow is normal and there is nothing wrong with that, then on AP and lateral view, once you know there is an undisplaced fracture, we can go for cast immobilization or even a splint, which can be given as well. And later on, at 5 weeks post casting, we can start with the normal range of motion. Coming to the displaced fracture. Now the displaced fracture means either they still could be extra-articular with an intra-articular extension, but the fracture fragments are displaced and quite apart. There has to be, first and foremost, is the reduction under general anesthesia. While initially the closed reduction is always attempted, under hematoma block or a Bayer blocks or even axillary block can be used, but sometimes you may require a GA so that the manipulation can be done easily and muscles are relaxed. Then the hand is grasped and longitudinal traction is applied. The first and foremost method of closed reduction is traction, countertraction. The distal fragment is pushed into the place by pressing on the dorsum of the fragment. Manipulating wrist into flexion is ulnar deviation and then is into pronation. That actually results in this. If there is a distal radius fracture, the distal fragment redislocates back into its position by using this. Initially you apply traction, then once the wrist goes into extension, once the extension is done, this unlocks the distal fragment which is actually impacted. Then you apply the flexion into it along with the ulnar deviation. Now remember, you cannot apply flexion more than 90 degrees. It should be only 40 to 50 degrees of flexion, and along with 10 to 15 degrees of ulnar deviation and pronation of the forearm. This dorsal plaster slab is applied, extending from below the elbow to the metacarpal neck. This is the area, and usually you can go above elbow as well, but usually they don't recommend it because after 2 weeks you have to go remove the plaster till below elbow so that some complete range of motion can be started at elbow joint. Initially, if we are keeping it for 4 weeks, it's better to keep it below elbow. 2/3 of the way around the circumference of the wrist is done and held in a position by crepe bandage. That is if you apply a slab over it. Or what you can do is, once you have reduced it, you can get a check X-ray, and if it's properly done, you can go for a plastering. Now coming to what happens next. The arm is kept elevated for next day. Shoulder, elbow and finger exercises are started. And if the fingers become swollen, we already have applied a splint, we can remove that, and we have to be on the lookout for the compartment syndrome all the time. Fresh X-rays are taken after a week. Redisplacement is not uncommon. Sometimes once more than one fragment is present, some do get displaced as well. Another at 18 to 20 days. And if it has displaced, we can go for manipulation again under GA and fixation with some internal fixators. Or if it has not displaced, we can go for a casting. Now coming to the displaced fracture, in older patients with low functional demands, outcome in these do not depend upon the anatomical reduction or perfect reduction anatomically. When we talk about anatomical reduction, which means is recreating the joint as it was previously before the injury. Usually there is no articular step, and if there is, there must be less than 2 mm. There should not be a lot of dorsal tilt more than 15 degrees or volar tilt more than 20 degrees, and at least the radial length should be more than 5 mm. Fixation of the fragile bone is sometimes difficult, so we may have to go for K-wire or internal fixation at times, and usually when we fix it, it's always associated with complications. Now coming to the displaced fractures, as we continuing with it, fracture line sometimes exits transversely in the central part of the distal radius joint. Sometimes when the interarticular extension is present and anterior cortex is intact, the dorsal fragment slips dorsally. This dorsal partial articular shear fractures usually are more stable in the cast and require surgical stabilization at times as well. Now, if the fracture can sometimes be reduced, held with percutaneous wires, or using a Volar locking plate. Now, there are a lot of options we have. We can do close reduction. Depending upon what type of fracture is, we can simply apply a plaster. If we think K-wires would be enough, we can go for a K-wires, or if we think this probably is an unstable variety and will shear off, then we can go for Volar locking plate as well. If the impaction is severe and reduction is not enough, or close reduction is not possible for some reason, then we have to consider either the dorsal plating by open reduction internal fixation. Although locked intermediate nails can be considered, but as this is highly very distal component, so usually they are avoided. External fixators are only avoided if we have an open fracture or lot of impaction is there and distraction is required for fixation. Other options could be an internal plate bridging radius to the third metacarpal, but that is only reserved for when we are going for wrist orthodesis, especially by internal plating. Now coming to the Volar locking plate, the most commonly used is for the distal radius displaced fracture is the Volar locking plate. Although it's expensive and requires a surgical skill, it's applied anterior to the distal shaft of the physis, as you can appreciate over here. And now there are anatomical plates which are available and they can be easily applied sufficient distally to support the fracture. What is important is, since there is a cutoff line over here, and you have to be very sure, because once you cross this line you actually fall into the joint. So it's requires a bit of more technical skill sometimes to apply it. And it should be proximal enough to avoid abrasion of the tendon. Sometimes they may be associated with post-operative tendon rupture as well. And above all, it should allow the stable fixation and early immobilization of the joint, because it's important the fracture should be immobilized and reduced as well. Other option which is more commonly used is the K-wires, as they are cheaper and more readily available. They are passed with care. An important point is not to impinge on the tendons, and usually they pass through the fractures fragments into the radius shaft. Two wires are more than enough, because one wire reduces motion in anterior posterior plane, other in superior inferior plane. So usually 2 wires are more than enough to reduce the motion in 3D. Pass through the fracture line, as the lever is called has Kapanji wires as well, and not strong enough to allow mobilization actually. But the problem with them is, when you have applied the K wires, you have to apply a slab so that you can reduce the motions at the fracture side till the fracture heals. So with the plate, you don't need to apply a plaster and keep the patient wrist immobilized. But with the K wires, you need to keep it immobilized for at least few weeks. So outcomes could be, sometimes it could be very good, but sometimes in older age group with a lower function amount, it's good, but regardless of the radiographic appearance. But it sometimes is also associated with poor outcome, especially once we have a malunited fracture, especially in the case of distal radius. It can be this kind of a problem in which there is ulnar deviation and there is actually positive ulnar variance. So sometimes for that we may require an osteotomy as well, and then there are different types of osteotomy which can be done as well. Poor outcomes is usually associated with, this is something you need to remember, that anatomical reduction is very important. Radial loss of radial length by more than 3 mm, which means that some books say 5 mm and others say usually the radial length is around 11 mm. That means the distal radius should be at least 6 to 8 mm ahead of the distal ulna, which is the radial length. Dorsal tilt of greater than 15 degrees is highly unacceptable. Why? Because a normal radial variance is such that it has a palmar tilt of 11 degrees. Similarly, even excessive palmar tilt is not acceptable, and greater than 20 degrees becomes unacceptable. And usually it has to be within the limitations as well. Above all, there should be no article step, and if there is, it should be less than 2 mm, which is the most important point, because later on it's going to develop arthritis. In this section, we briefly discussed what the displaced and undisplaced fractures are. Undisplaced fractures, once we have got the AP in the lateral views and we are sure there are no associated injuries, can be safely managed in the traction, or even with the splint can be applied, and once the swelling settles down, range of motion can be started at around 4 to 5 weeks. If it's displaced, the first and foremost we can reduce it closely, and once we have achieved the close reduction, we can see whether we have achieved the anatomical reduction or not. If we have achieved the anatomical reduction, we can safely apply a plaster, or if we have not, then we can go for other options as well, which includes, it could be in form of a K-wire, it could be in form of Volar or dorsal plating, or it could be in form of a distraction fixator being applied across the wrist, showing it as an external fixator. Usually the anatomical reduction criteria for the distal radius fractures are that there should be article step should be less than 2 mm, volar tilt should be less than 20 degrees, dorsal tilt should be less than 10 to 15 degrees, and there should be usually a radial height, a radial length should be more than 8 mm or 6 to 8 mm. Thank you very much. Keep watching sqadia.com.